Hi, everybody. Dr. Rob Silverman here. I've got my esteemed colleague, Dr. Ben Weitz. Dr. Weitz is a sports chiropractor and functional medicine practitioner from Santa Monica, California. He has, without question, 35 years of experience. One of the areas of focus with functional medicine that we'll be discussing today will be managing functional gastrointestinal conditions. He has a successful podcast. I recommend everybody follow it at Rational Wellness. He wrote the Back Relief book and is currently working on a book on longevity. Dr. Weitz, it's my pleasure, my friend Ben. How are you doing?
Thanks, Rob. I'm very happy to be joining you today.
I'm happy you're here. So tell me a little bit about this idea that you're going to be writing about longevity. That was not a surprise, but it was a happy moment for me.
Well, I was working on a book on longevity and I threw it aside, and now I think I'm ready to go back and finish writing that book.
All right. I wait. I hope I get that pre-order copy.
Absolutely.
Any insights to what you got in there, or you don't want to give it away just yet?
No. I just started getting back to it again.
All right. So I asked Dr. Weitz on, Ben, my good friend. I mean, with this 35 years of experience and this transition from chiropractic into functional medicine, one of the big things that he addresses in the California area is small intestinal bacterial overgrowth, SIBO. So interesting that we're going to get into the details. We're going to get a little granular with it. And I'll say this, we all talk about leaky gut. I mean, you can go on any podcast and you hear about leaky gut. I believe in 3 years, we'll be having the conversation of small intestinal bacterial overgrowth.
Yeah, I think it's more specific. I think it's more testable. And I think it's more treatable. I mean, we all treat leaky gut, and I think leaky gut is a significant problem, but the testing is questionable. And I think levels of intestinal permeability come and go. But I think when it comes to SIBO, this is a condition that I think we can address, and I think we're going to help a lot more patients focusing on SIBO than we will on focusing on leaky gut.
Interesting. I hear the gut panel right now ready to have a gut check. But that said, I'm going to ask you, what's the most common gastrointestinal condition?
IBS. IBS occurs in up to 20% of the population, also known as irritable bowel syndrome.
Why? I mean, that's a basic question. Why do so many people have irritable bowel syndrome, and what are some of the symptoms of IBS?
Right. So the main symptoms of IBS are gas and bloating, either diarrhea, constipation, or sometimes alternating. Sometimes there's bowel urgency, and often there's some level of stomach pain or discomfort. There can also be nausea and skin problems and a whole bunch of other things, but those are the main ones. And, for many years, IBS was really just a diagnosis of exclusion, meaning somebody would go to a gastroenterologist and complaining, say, of diarrhea and stomach pain and bloating, and they would do a scope. They do a colonoscope from the bottom up. Maybe they do an endoscope from the top down. And if they didn't see any structural damage, they would say it was IBS. And so that's why IBS is essentially referred to as a functional disorder, meaning that if you look inside, either with a scope or you do a scan of some kind, you're not going to see any obstruction. You're not going to see inflammation. You're not going to see damage to the intestinal wall. You're not going to see anything structural. Essentially, you'll see a normal mucosa through the intestines. And then I think that for many years, it was often thought that IBS was a stress issue. And this was partially because it was much more highly prevalent in women. And the thought was that they can't handle their stress, and that's causing all these gut symptoms. And at one time, doctors used to prescribe antidepressants. And it's still on a list of potential medications. And the interesting thing, though, is there may actually have been a physiological reason for prescribing SSRIs or antidepressants, and not because IBS is caused by stress primarily, but because their serotonin receptors in the small intestine, when you stimulate those, they actually improve intestinal motility.
Body's all interconnected. It's interesting, serotonin. So that idea about gut check and gut feeling really comes to light with that anatomical explanation. So I get this question a lot in the office. IBS. What causes IBS? Give me some of the
Okay,
examples.
so Dr. Pimentel and his group have been doing a lot of research on this, and especially this year with the papers they've just published and presented at gastrointestinal conferences, we can now say with good authority that 60 to 70% of the cases of IBS are caused by small intestinal bacterial overgrowth, or what we call SIBO.
So that's interesting. So small intestinal bacteria overgrowth, excessive bacteria in the small intestine, because in comparison, the small and the large intestine, the small intestine is not supposed to have too much bacteria. We've always talked about it between the two of us. It's the largest section in the digestive tract, and the small intestine is where your nutrients, your vitamins, your small digested food particles occur. All right. But IBS, isn't that in the large intestine?
No, IBS, it just refers to a set of symptoms.
Okay, because again, I have patients that come in and say IBS is large, leaky gut and SIBO is in the small intestine.
That's not the case. Yeah.
I'm happy that you get the clarity. SIBO, all right, since it causes IBS, it begs the question, what causes SIBO? And do you have some stats on SIBO?
Right. So first of all, I just want to explain why small intestinal bacterial overgrowth leads to these symptoms.
Great.
And part of it has to do with the anatomy. So if you look at the colon or the large intestine, it's a large, very expandable tube. And so it's normal. That's where most of our microbiome is. So there's literally trillions of bacteria in the large intestine. And it's normal for those bacteria to ferment or produce gas. And producing gas involves producing short chain fatty acids, vitamin K, all these different nutrients. So bacterial fermentation is essentially a good thing. It's not a bad thing. The problem is that the small intestine is a relatively narrow tube and it can't just balloon out. So if there's a bunch of gas being produced in the small intestine, it's going to be uncomfortable, and it can have all sorts of effects. It can push up. It may even increase the risk of reflux or heartburn. And because the small intestine is the site, as you mentioned, where we absorb most of our nutrients, if you got some extra bacteria lining that mucosa, it's going to interfere with the absorption of nutrients. So we have to keep the level of bacteria in the small intestine down to a lower amount. Now, what causes SIBO? So there's a number of factors that we think play a role. One of the mechanisms that Dr. Pimentel has pioneered is that it's actually an autoimmune disease. So what happens is you get a bout of food poisoning, and a lot of people get food poisoning and don't even know they had food poisoning. They just go, oh, I just ate something bad. I don't know why. I had some stomach pain. I had the runs and now I feel better. So what happens in food poisoning is you get a bacteria, Campylobacter jejuni, E. coli are two of the more common bacteria. And so what happens is that bacteria secrete an endotoxin. It's common for bacteria to secrete endotoxins, and these toxins can have all sorts of damaging effects on the body. And so in this particular case, they secrete an endotoxin called cytolethal distending toxin. In fact, cytolethal distending toxin B. And Dr. Pimentel did develop a blood test that can test for this. And so what happens is we get immune reactivity that damages the motility of the small intestine. And interestingly, Dr. Pimentel and his group have actually helped to further provide proof for a mechanism of autoimmunity that's very common that we discuss, Rob, all the time in the functional medicine world, which is molecular mimicry. So what happens in this case is the immune system reacts to this cytolethal distending toxin. It produces antibodies. And then those antibodies recognize a structural protein in the wall of the small intestine known as vinculin. And so the antibodies attack vinculin, and that damages the motility of the small intestine. When you have decreased motility, especially when you damage the migrating motor complex, it decreases what are called the cleaning waves or cleansing waves. So understand this. We all have a certain amount of motility. We have these waves, peristaltic waves that occur when we eat food. So we eat food, it makes its way down, and the intestine slowly contracts to push the food through. But now, when you haven't eaten for 3 or 4 hours, we also get peristaltic waves. And these peristaltic waves are known as the cleaning waves. And these cleaning waves help keep our small intestine clear from bacteria. So what's happening in this case of SIBO via autoimmune origin is that we're not getting the cleaning waves, and that increases the likelihood of bacteria building up. Now, other mechanisms that increase the likelihood of bacteria building up.
I'm going to pull the plug on you for a second because you gave so much. I got to recap for everybody listening. So great takeaway, everybody. I have not heard it. The small intestine is small because it's very small in diameter.
Yep.
So Dr. Weitz talked about, gas and making it go and blow up like a balloon, stretching it. That's why your discomfort comes from. Bacteria in the small intestine does digest carbohydrates, and then it converts it to gas and short-chain fatty acids. That's a good thing, like he said. Unfortunately, too much bacteria leads to more gas. The byproducts can result in diarrhea, hence the idea of the bloating sensation, that stomach bloat and the diarrhea. Bacteria also consumes protein and B vitamins and bile salts, huge component. They're actually meant for us. This can lead to poor digestion of fats, nutrients, especially calcium and fat-soluble vitamins. Ultimately, if just SIBO, you'll have some GI symptomology, gas and bloating, and typically diarrhea. Then he got into the real details. He got into the good weeds. In that one, food poisoning leads you down a path of IBS and or SIBO. Bacteria do secrete. There's an endotoxin called cytolethal distending toxin. There's also another endotoxin in the gut that I talk about called LPS.
Yeah.
Cytolethal distending toxin is 11 times more toxic than LPS. I mean, I like that name so much, they should make it a villain in a new James Bond film. And
there you go.
That endotoxin causes that great
that'll be the functional medicine version of the James Bond movie.
Without question. And James Bond will now be called commensal bacteria.
Which you'll be able to watch starting next month on Rob and I's new streaming service, the functional medicine streaming service.
You made a great point about how it attacks, and now there's a blood test, which is good. I wanted to get to. And I thought what was really a salient point was the migrating motor complex, which is peristaltic wave-like contractions. But you're right, they're cleaning waves because they move the food bolus from the stomach to the small to the large intestine. So I think now we're here. So take it from here, take us through our SIBO journey.
Yeah. So one of the things we've learned about SIBO is, and we've only learned this in the last couple of years, there's actually 3 different varieties of SIBO. Oh, you know what? Before I get into that, let me just mention a couple of other mechanisms besides damaging the cleaning waves that increases the likelihood of SIBO. One of them is if we have decreased or insufficient levels of digestive enzymes, if we have insufficient levels of hydrochloric acid, if we have insufficient levels of bile. Now, those are all necessary for digesting the food, but they also help to keep the small intestine clear of bacteria. Other mechanisms that can increase the risk of SIBO, well, of course, there can be structural issues. So if there's any sort of scar tissue in the small intestine, that'll slow the movement of things. And when you have a stream that's not moving freely, then you'll get an overgrowth of algae. You see a stream and it kind of backs up here and then you get that green algae. So we need the stream to be moving freely. And if there's any sort of structural issues like scar tissue or other damage to the intestines, that can affect and increase the likelihood of SIBO. Also, if there's any problems with the valves that block the food from coming back up from the large intestine into the small intestine, what we call the ileocecal valve, that can be a problem. So there's also a number of medications that increase our risk of SIBO, including non-steroidal anti-inflammatories, overuse of antibiotics. We have, this is controversial, and I know that Dr. Pimentel's data has shown that there PPIs or proton pump inhibitors, which are often prescribed to help control heartburn or reflux. His data shows they don't increase the risk of SIBO, but my experience with patients is I've seen a number of patients where it certainly appears as though it's increased their risk of SIBO by decreasing that hydrochloric acid, which we know is necessary to keep the bacteria down. Anyway, so now I want to go into the forms of SIBO. So we have 3 different.
I got to stop you again.
Okay.
You're giving so much qualified information.
Okay.
So you basically talked about the different causes of SIBO. So motility, migrating motor complex. You did a great job. Obviously, cytolethal distending toxin. You talked about some other kind of issues. I'm going to kick a couple in there for you. Vagus nerve damage.
Yes. I'm sorry.
Diabetes.
I should have mentioned that.
Diabetes. It's all right. That's what we're here for. That's why it's 2.
Yeah, we've actually been working with a vagal nerve stimulator that uses electrical current over the vagal nerve. And it's kind of interesting. We seem to be getting some good results. I know you use a laser on the vagal nerve, and I've used the laser on the vagal nerve as well.
Yeah, I think what you mentioned, the stimulator, I think that the physiological side that Andrew Huberman made so popular now, everybody's talking about, and not that he created it, he just brought it to the forefront. Again, laser, some of the other things, obviously diabetes. Listen, I'm sure you and I would agree that blood sugar dysregulation is the number 1 problem that we face in America today because it's based on a poor diet. We're not going to go down that particular rabbit hole.
Hey, hypothyroid increases your risk of SIBO because it decreases motility.
Right. Any kind of chronic infection, like viral infections, post-COVID, if you will, Lyme disease. So there's a lot of factors. There's one that I always love to talk about is concussion. 60% of people post-concussion either have leaky gut or SIBO because concussion decreases the vagus nerve tone, which is an issue, and also slows down the migrating motor complex, works on the ileocecal valve. You also talked about impaired digestion, decreased bile flow, stomach acid, pancreatic issues. You did a great job of talking about some of the structural issues. I mean, we're chiropractors, but people have C-sections, scar tissue adhesions, gallbladder, all sorts of things like that. And it gets to
they get kicked in the stomach. They, all sorts of things. They fall.
How about endometriosis? Do you think that has an
Oh,
impaired?
absolutely. Absolutely.
And I agree with you on the PPI. I think they're so egregious. And not that we're trying to
And they're
disagree. We're
handed
looking at
out like
different.
candy, got a stomach problem, PPIs, got acid, PPIs, got, heartburn, PPIs, have stomach pain, PPIs.
And they're supposed to take it for 4 to 8 weeks, and they take it. I have somebody who's taken it for
For
19
years.
years.
Yeah.
19 years,
Yeah, I
two
know.
decades. It's
Right.
old, it's older than my niece. I
And
mean,
then
goodness
shocker,
gracious.
now they have osteoporosis. Now they have all these other problems.
H.
If
pylori.
you decrease your hydrochloric acid, you're not going to be able to absorb your calcium. You're not going to produce vitamin B12. You're not going to, hydrochloric acid is crucial for the normal functioning, not only of the GI tract, but of our body.
Now, you wanted me to give you a moment to assess and diagnose patients with these conditions. I think you wanted to get onto that in some of the tests.
Yeah. So I wanted to say, first break it down into 3 different types of SIBO. And that basically is based on the gases that are produced. And the way we test for it is with a SIBO breath test. So the 3 forms are, we have hydrogen SIBO, we have methane SIBO, and that's been renamed. And we now know we have hydrogen sulfide SIBO. And so this is all based on the gases that are produced, and the gases are measured by the SIBO breath test. And the best way to conduct a test, in my opinion, is to use lactulose as a substrate. Some people use glucose, and I know there's some data showing that there's some benefits to using glucose, but I have not found glucose to be an effective way to do it. Dr. Pimentel, who's really the king of SIBO, doesn't recommend glucose. Allison Seebecker, who's the queen of SIBO, she doesn't recommend glucose either. The problem with glucose, it gets absorbed in the first part of the digestive tract, and it doesn't make its way all the way through, so you can't really test. So lactulose is a sugar that will feed the bacteria and lead them to produce gas. So we use this SIBO breath test as a good way to diagnose it. And now I think the new data shows that we probably need to use a stool test as well. And the reason for using a stool test is that the form of SIBO that we previously referred to as methane SIBO, we now recognize as an overgrowth of methanogens. And methanogens are not just in the small intestine, they can be overgrown in the large intestine too. So Dr. Pimentel now refers to it as intestinal methanogen overgrowth, and the acronym there is EMO. And so while the SIBO breath test is a great way to pick up on the methanogen overgrowth in the small intestine, we really need the stool test to measure the methanogen overgrowth in the large intestine. And by the way, methane SIBO or EMO and the methanogens are actually microorganisms known as archaea. And archaea are primitive microorganisms, and they're totally separate from bacteria. And it's really fascinating. As we learn more and more about how human beings were formed and about biology and everything else, we're learning that these bacteria and archaea actually played very crucial roles in our development. And I was actually just listening to a discussion between Jack Cruz and Andrew Huberman, and they were talking about how all of us know that the mitochondria in the cells we believe are produced by bacteria that were incorporated into our cells. There's a certain amount of data to show that the nucleus of the cell actually is an archaea that was incorporated into our cells.
Wow.
So anyway, these methanogens, the most common one is Methanobrevibacter brevi, is what causes the methane SIBO. And so, as I was saying, we want to do the breath test, and then we want to do a stool test that also includes looking at Methanobrevibacter smithii. That's what I meant to say. That's the full name of the archaea, Methanobrevibacter smithii. And so we typically use the GI map stool test from Diagnostic Solutions, and that includes Methanobrevibacter smithii. It also has a section where it includes several other bacteria that are often causes of SIBO, and that may or may not be beneficial as well.
So you start with the breath test.
I usually have the patients do the breath test and the stool test if they're willing to do both.
Okay. What about any blood work? Would you recommend any blood work? Do you feel it's diagnostic enough for SIBO at this point?
Yeah, look, I love doing testing. If it was up to me, I would spend $5,000 on blood on lab testing. However, most of my patients don't really want to spend that much, especially out the gate. So depending, we can do the IBS SMART test, which is a test for the antivinculin and anti-cytolethal distending toxin antibodies. So that's a test that can be done. You can test for leaky gut using lab work, using blood testing. I love doing advanced lab panels. Patients are having SIBO. They're likely having nutritional deficiencies. I love testing for micronutrients. I love doing functional oriented lab testing. So it depends. But at the very least, it's very helpful if we can do the lactulose SIBO breath test and the stool test.
So they test positive for small intestinal bacteria overgrowth. And like you said, you want to save them a little money. We're all about lifestyle. That's the one thing that we all have in common, giving good qualified lifestyle hacks. So what dietary and lifestyle interventions would you recommend with patients with IBS and SIBO?
Okay. So as far as diet goes, we know that fermentable fiber is what feeds the bacteria. So generally speaking, I try to come up with dietary recommendations that reduce the amount of fermentable fiber. Now, I don't think we have to be Nazi commanders about this. I don't think we have to tell people they can never eat a food that has fermentable fiber, because I do think it's a matter of the amount of fermentable fiber. And for some reason, some people can eat certain types of foods with fermentable fiber and they can't eat others. And I can't fully explain that. Maybe it has to do with the way their body's ability to digest those foods. Maybe there's food sensitivities that play a role. But generally speaking, I'm going to give them a recommendation to reduce the foods that are higher in FODMAPs, which is essentially another way of saying foods that are higher in fermentable fiber.
So FODMAP, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols.
Yes.
Now, I hear you, and I'm going to be the patient, or I'm going to be some of the patients, and you're laughing because you know what I'm going to ask because they've done it to you. How compliant can people be? And we never want to be negative, and we never blame the patient. But if they stick to the FODMAP, I'm sure you find that the FODMAP is a fabulous diet. But one, what percentage of people do? And two, if they don't, a lot of patients ask for an alternative. So I'm serving up the softball.
Yeah, no, absolutely. Look, I cater my recommendations to every patient, partially based on what I gauge is their level of commitment and their personality and a bunch of other things. So, part of it's my women's instinct when I'm talking to the patient. But so I may make very strong recommendations and say, look, I highly recommend that you minimize this list of foods. Here's the list of foods that are lower in FODMAPs, and feel free to eat as many of these foods as you want. Or I may say, let's just take out some of the highest FODMAP foods. A lot of times when I talk to patients, they'll say, geez, I just can't eat cabbage. I can't eat beans. It just bloats me like crazy. So they already have a sense of some of the foods. They have issues with gluten. They have issues with dairy. So, there's one practitioner who actually came out with a point system where you, instead of tell people not to eat certain foods, you rate the foods based on the amount of fermentable fiber and just stay under a certain amount of points. I hate telling patients not to eat super healthy foods like broccoli and avocado. So I'll ask them to just have a smaller amount. Make sure the broccoli is steamed instead of raw.
Right, because you want to get sulforaphane, and you're able to get sulforaphane with cruciferous vegetables.
The other thing about there's some controversy, of course, about everything in functional medicine, and especially when it comes to diet. And so if the person is being treated by a gastroenterologist and they're taking, instead of seeing me or you, Rob, they see a gastroenterologist, and the gastroenterologist recommends antibiotics like rifaximin. Antibiotics are believed to work by affecting the replicating cell wall of the bacteria. And so I know Dr. Pimentel feels, and there's a certain amount of data to support the idea, that you don't want the bacteria starved of fermentable fiber when they're on antibiotics. You want them happy, replicating and producing, as they're replicating. That's how the antibiotics kill them. Now, we don't believe that herbs that I use in my practice work the same way. So I find it more beneficial to have the person reduce the fermentable fiber at the same time as they're taking the herbs. But
yeah, so let's dig into that. What are some of the more effective nutritional supplements for treating these conditions? And then I'm going to piggyback. I'm going to ask you two big questions, one of which will be antibiotics. So, get your politically correct hat on for that one. But what are the supplements they can take?
Well, first of all, it depends on the person. It depends on the SIBO, whether there's different herbal antimicrobials that tend to be more effective for hydrogen SIBO versus methane SIBO versus hydrogen sulfide SIBO. I'll give you some of the categories of herbal antimicrobials, but of course, the exact product and dosage and the combination is where I think a lot of the magic is. But among the herbal antimicrobials that we find effective are berberine, oregano, neem, allicin, which is the extract from garlic. Bismuth is a mineral that's used in some of the protocols, and so there's a number of other herbal antimicrobials and combinations of herbal antimicrobials that we'll use. And often I'll rotate the herbal antimicrobials on a monthly basis if the person needs more than a month of treatment, and most of the patients do, so that bacteria don't get used to them.
Excellent.
In addition to that, we may use biofilm busting agents because bacteria in the intestines tend to form biofilms. Biofilms are ways that the bacteria can wall themselves off from the immune system and make it harder for the immune system to affect them. And so we may use enzymes. There's a number of different products that we may use to help to break up those biofilms. Now, other things that are important is how well is the immune system of your gut functioning? Because no matter what we're using, whether you're using antibiotics or whether you're using herbal antimicrobials, those products alone are not going to kill the bacteria without the immune system doing a very significant part of the job. Just like with cancer or anything else, you can use the harshest chemo medication. If the immune system's not playing a significant role, you're not going to get anywhere with curing that cancer. So we need the immune system to be working optimally. And that's one of the reasons why I like doing a stool test that measures secretory IgA, which is one measure of the immune system function in the gut.
Right. Secretory IgA, great choice. It's at the gut level, that's the mucosal level, very high concentration of that gut. You also have the lung and also the mouth.
We know the immune system, 80% of the immune system is centered around the gut. Now, why is that? Because we only have a couple of openings to the outside world. We have the nasal cavity, so stuff you breathe in. You can breathe in bacteria and viruses, or we can ingest it. And so, therefore, we're getting a lot of our exposure to microbes through the gut. So therefore, 80% immune system is centered around the gut. We've got to make sure that part of the immune system is working well.
It's funny, they talk about the gut microbiota, and people don't realize that the gut microbiota goes from the mouth all the way through down, like you would say, the alimentary canal through your anus. And the reason, you really just magnified it, the reason that 80% of your immune cells are in your gut is air and also the foods that we consume.
Exactly.
And that's why SIBO can be so detrimental to one's overall health. So you gave a whole bunch of nutrients. You gave some also lifestyle interventions. Let's ask the big question. And boy, I'm putting the sword down so you get to fight. I'm going to stay out of this. I'm going to shut my camera off. Do you take probiotics with SIBO?
I've gone back and forth on this. And there is a prominent practitioner in the functional medicine world who feels that probiotics should be first-line therapy for SIBO. And the claim is made that probiotics are antimicrobial. And there are some studies that show there's some benefit with SIBO from taking from using probiotics. And then there are some probiotics that supposedly don't colonize the small intestine, i.e. soil-based, spore-based probiotics. And so I have experimented with using spore-based probiotics with patients with SIBO. And the idea is that the probiotic the spore doesn't release until it gets into the large intestine. But
where the bacteria is supposed to be. So the spore is like an acorn.
Right.
If you will.
So I have come to the conclusion after continuing to read the research and watch the results I get with hundreds of patients. I generally do not recommend probiotics when we're in the active phase of reducing bacterial overgrowth. I save that till phase 2.
Okay, so the initial phase is without a probiotic. Second phase is with a probiotic. And I don't know if I have the courage to ask about prebiotics.
Same thing. I mean, you don't want to, fermentable fiber are prebiotics. So you definitely don't want to use prebiotics in the initial stage of fighting SIBO.
Two chiropractors about to ask the question and answer the question. What do you think about antibiotics for small intestinal bacterial overgrowth?
The main antibiotic that a lot of gastroenterologists will use is a antibiotic known as rifaximin that Dr. Pimentel pioneered for this. And it's claimed that rifaximin only works in the small intestine. It's not absorbable. And so I have seen some patients get better taking rifaximin. I've had patients just take 2 weeks of rifaximin, end of story, SIBO gone. But I see a lot of patients who don't do well with rifaximin. Either didn't help at all, or the symptoms came back pretty rapidly, sometimes worse. So I do think that some patients are benefited by rifaximin. There's certainly some good data on using rifaximin. I do think we want to try to limit the use of broad spectrum antibiotics. But in particular, the methane, because they're primitive archaea, are very problematic trying to eradicate them using antibiotics, which are designed to kill bacteria. And they're not bacteria, they're archaea.
So with SIBO, there has a tremendous amount of recurrent rate, meaning it comes back. As a matter of fact, it's the study I'm looking at right now talks about 50% within a year, but the bulk of the time it comes back within about 2.5 months. Can you speak to that? Is it the underlying causes are not treated? They're not doing the type of testing that you're doing. They're relying on just maybe an antibiotic and not a nutritional protocol, etc. Can you go into that and what you've seen and how it's really changed and varied over the years?
Right. Well, I think first of all, if we do the proper testing, we really know what we're talking about. We're not just guessing. Number two, one of the reasons for doing a stool test in addition to a breath test, if we get the patient's compliance, is there may be layers of problems in the gut. So, I was just examining a patient who was getting tingling in her fingers, and she was like, is it carpal tunnel? Is it cervical radiculopathy? And, in her case, it was both. And I think it's often the case in the gut, there's more than one problem. So I'll see a lot of patients and they'll have SIBO, but they also may have candida overgrowth. They may have a dysbiosis. They may have an overgrowth of friendly bacteria. They may have a parasite. They may have a protozoan. So a lot of times we'll have to have a couple of phases of treatment. We'll have to treat the SIBO, and then we'll have to treat the other underlying problems. Another reason why SIBO tends to recur is not addressing motility. So what Dr. Pimentel typically will do is treat the patient with antibiotics, and then he'll give them a prokinetic drug. What I do, I tend to use a prokinetic nutritional formula at the same time as we're treating the SIBO. So we'll use a product that has a combination of nutrients. Typically, it'll be things like ginger, artichoke, sometimes 5-HTP. Remember, we talked about the serotonin and how serotonin receptors in the small intestine stimulate motility. So we'll use a product like that to reset the motility. And then if we feel like we killed off enough of the bacteria, I may have them continue taking the natural prokinetic for a number of months longer.
Interesting. Now, you mentioned, just as an example, you talked about some different musculoskeletal ailments, and I'm going to piggyback and expand about the idea of the gut is the epicenter of our health. As you said, 80% of our immune cells are in our gut. And one of the biggest things that we do as chiropractors who went into functional medicine is to talk about the gut to joint axis. So you were giving a classic example of joints, but within the communication of small intestinal bacterial overgrowth. But I do want to get back. You talked about the stool test being so revealing, and we talked about SIBO and IBS. So IBS, you would be looking for fecal calprotectin and probably lactoferrin. So if you could go through that with the stool test that you're able to diff dye between the IBS and the SIBO because of that, I think people would find that very illuminating.
Well, in terms of inflammatory markers on the stool test, part of it depends if they come up positive, how positive are they? So one of the reasons for including inflammatory markers is to rule out inflammatory bowel disorder like Crohn's or ulcerative colitis. And those are very serious medical conditions and need to be taken seriously. Those are just not just functional gastrointestinal disorders, but if you put a scope and look inside somebody's intestines who has ulcerative colitis or Crohn's, you're likely to see inflammation of the mucosa. You're likely to see damage, maybe bleeding of the inside lining of the intestines. And so that's one of the reasons. So if those inflammatory markers are very high, they may be indications of that. And if that's the case, then you definitely want to make sure that the patient is being co-managed with a gastroenterologist who's doing a scope or a scan or both.
Now, before we went on, we were talking about leaky gut, and we really wanted to speak more about small intestinal bacterial overgrowth, more about IBS. But I said that SIBO can cause leaky gut. Leaky gut doesn't necessarily cause SIBO. And you agreed with that as a general statement.
I do.
What other conditions can SIBO cause? So people say, I just have SIBO, I get a little gas, I get a little bloating. You know, by the way, I think a memo to everybody is you're not supposed to get gas and bloating after you eat. You're not supposed to have brain fog.
Right. Absolutely.
So tell them about some of the other downstream effects and the peripheral effects that SIBO.
Well, you know, we already mentioned nutritional deficiencies. You want to talk about the largest number of unhealthy conditions that can happen in the body, including everything, including Alzheimer's, including Parkinson's, is having nutritional deficiencies. By the way, Parkinson's disease, which is the chronic degenerative neurological disease that's increasing at the fastest rate in this country, is preceded by constipation by sometimes 15, 20 years earlier. So we know there's a big gut component related to Parkinson's. Wouldn't it be great if we paid attention to that and took the person with constipation and improved the health of their gut and had a decrease in their likelihood of having Parkinson's later? So nutritional deficiencies can lead to osteoporosis and heart disease and almost every disease known to mankind.
Yeah, again, I'm going to really piggyback on what you just did say, in that about the neurodegenerative disease all have a gut issue, and Parkinson's is autoimmune. It's bidirectional. Alzheimer's is now autoimmune, the sixth leading cause of death. It's been stated, or at least postulated, that 50% of Americans will have a symptomology by 2050 of neurodegenerative disease. And when is the more provincial medical model going to start looking at the gut as the origin? Hippocrates said all disease begins in the gut. Alessio Fasano said all disease begins in a leaky gut. Weitz and Silverman are saying we may have to say all disease begins with SIBO in the gut.
Yeah, but let me tell you something. Weitz and Silverman don't have much of an effect on who controls the healthcare system. And insurance companies, they don't give a bleep about the gut. They want to compartmentalize everything and find the least expensive way to treat everything. So if you got SIBO and you got diarrhea, here's a drug for diarrhea, go away.
And that's why functional medicine, I think, for us was so compelling, in that it put the idea of root cause resolution. And SIBO, I hate to say it, in leaky gut isn't root cause resolution. It's what caused it. They are diagnosis. But what caused SIBO? Was it the migrating motor complex? Was it diet? Was it PPI, if you will, leaky gut?
Right.
Was it gluten? Was it
Right.
dairy? Was it a food sensitivity? And that's why it was so compelling. And I think that's where medicine is going. And I'm seeing that transfer from medical doctors, osteopaths, physical therapists, chiropractors, nurse practitioners into this model, which we, with all due respect to Dr. Bland, who created functional medicine, we're getting into the functional idea of trying to examine the body, because we know it's an interconnected organism. There's 14 systems with a myriad of symptoms that really will allow us to get to that root cause. So everybody, if you're going to a doctor now, for whatever your condition is, you want to know why you got it, not just what you have.
Right. And how can you treat the underlying cause and not just the symptoms? So if you're being given a medication, ask, what is the benefit of this medication? How is it working? And what is it doing for me? If the medication is just to reduce diarrhea, but it doesn't do anything about the reason why you have the diarrhea, then it's only going to be a short-term fix or something you're going to have to take for the rest of your life, like a PPI, to control the acid. Why do you have too much acid? Why do you have heartburn?
Right.
And, here's one question nobody's even asking. This is a whole nother ball of wax is, finally, we've come up with the main cause of IBS. Unfortunately, the studies are indicating it probably causes 60 to 70%. What about the other 30, 40%? What are those causes for IBS? How many of those maybe are fungal overgrowth?
Now, within IBS, real quick, what would you do as a protocol to help someone that you ascertained had diagnosed somebody with IBS?
Well, try to find the underlying cause. Do they have SIBO? They don't have SIBO. What are some of the other possibilities? Like, could be fungal overgrowth, could be parasites, could be dysbiosis.
Are you saying there's something called SIFO, small intestinal fungal overgrowth?
Yes, sir. The problem is we don't have a breath test to diagnose SIFO. And stool tests are not as accurate as we'd like them to be for diagnosing fungal overgrowth. So sometimes they're helpful. And we do pick up candida and other fungal organisms on stool tests, but not always. And I think we're missing a percentage of patients. So I do think that being able to better diagnose fungal overgrowth is something that we need to develop. We do sometimes use an organic acids test, and that's another way to get an idea of whether there's fungal overgrowth.
Excellent. So as we close, people always want to know, can you give me like 3 things to do to make me healthier for tomorrow, and obviously try and avoid small intestinal bacterial overgrowth and IBS?
Well, number 1, eat healthy. Number 2, don't graze all day long. You need to have periods of time during the day when you don't eat any food. I know I was raised on this idea. I did bodybuilding when I was younger, and we had this concept that you had to eat a meal or snack every 3 hours a day. If you went more than 2 or 3 hours without eating, your blood sugar would drop, you'd gain body fat, you wouldn't be building muscle. It was bad. Now we know that having extended periods of time where you don't eat is beneficial. It's beneficial for our brain. It's beneficial for a lot of systems. It's also beneficial to decrease SIBO. So those are 2 important things. Number 3, chew your food carefully. Chew every bite at least 10 times. Undigested food particles lead to higher likelihood of your immune system reacting to your food and then cross-reacting to your intestines and creating problems.
So how can they get in touch with you? I mean, I'm going to give you a big plug, Rational Wellness, your podcast, blowing up.
Absolutely. Check out Rational Wellness, wherever you get your podcasts, on Spotify, on Apple Podcasts, There's also a video version on YouTube. Go to my website, drweitz.com. That's drweitz.com. Or call my office at 310-395-3111. And we can get you an appointment for a functional medicine consultation.
Outstanding. Well, it's been my pleasure. It's always great to talk to one of my colleagues, really share some information, and you just have a good old time. And we look forward to hearing from you. Feel free to reach out, put some comments and questions when you see this live. We'll definitely get back to you. Dr. Weitz, it's been my pleasure. Ben, thanks for coming on. I'm Dr. Rob Silverman, always yours in health. This is Proven Health Alternatives.
Thanks, Rob.